Good morning, Largo Medical Center. Looks like you've got a mic, but it's not turned on. It's never turned on in Largo. Largo is silent again. So this is welcome to our conference today for WFLHCA. This is our 50th recorded conference. I think we have some we didn't record, but this is our 50th recorded conference. So we want to welcome you to Advanced Cardiac Imaging. And today we're going to talk about a friend of ours called atrial fibrillation flutter. And so let's start out with SW when we first saw him at age 49 in 2008 after an episode of palpitations, which he's been having off and on for years. And so he is a plaintiff's attorney, which is important because you don't want to be sued for malpractice by a plaintiff's attorney who's your patient. And so I don't know if that would be a conflict or not, but it's interesting. So this gentleman is very active athletically. He does golf, tennis, gets dehydrated, gets palpitations when he's dehydrated. We'll have to talk about some of the provocateurs for causing atrial fibrillation flutter. So for him, the number one provocateur is dehydration. And so his heart rate jumped up. He came to the emergency room to get evaluated, not knowing much about what's going on, but knowing that he's having an arrhythmia and knowing that this is longer than he's ever had it, but he's had it off and on for years. And so he wanted to find out more about this. This is a very sophisticated gentleman when it comes to medicine. He knows certainly as much as a med student does and is very savvy. And so you have to remember that you're one unit clerk away from the smartest malpractice attorney in town. So that's why you got to be careful and mind your P's and Q's. So let's look at this gentleman, his history. He's had two previous hospital visits, 1997, 2003. So they're pretty far apart. It looks like 5 years this time, and before it was 6 years. So few and far between. Don't know much about the 97 and the 2003. Not much past medical history. He does have Gilbert syndrome where he has a little bit of elevation of his bilirubin. And no family history of arrhythmias. So that's good because we see a lot of familial atrial fibrillation. Smokes, has 2 or 3 beers 3 or 4 times a week. There's a nice provocateur. Alcohol is a very common provocateur. And actually I had a lady in her 80s who one drink of wine and she got atrial fib, and she said, I'm willing to take any drug so that I can continue to have my drink of wine at night. And she did. She took amiodarone. And so that's going to an extreme for a glass of wine. And so irregular rate and rhythm, otherwise unremarkable. Here's his EKG a week ago. I don't know why he had an EKG a week prior to presentation, but he has a profound sinus bradycardia. So it looks like a lot of parasympathetic activity. So we do find the atrial fibrillation flutter that's induced by patients who have high parasympathetic activity. They usually get it at night. They wake up with it very frequently. They also can get it from other provocative agents. Looks like alcohol is pretty common. Dehydration is very common. Caffeine is very common. Exercise causes the induction of atrial fib in those who are more sympathetic rather than parasympathetic. So the parasympathetic people are usually the marathoners, and they have a slow heart rate, and they have a predilection to paroxysmal atrial fib. They usually have bigger ventricles, a little thickening from the athletic heart, larger left atria to be able to accommodate being a marathon runner. And so all those things may lead to atrial fibrillation flutter. Here he is on this poor reproduction of his EKG that certainly shows a lot of sawtooth type activity in here. So perhaps this is more of a flutter. We don't call it flutteration, we call it fibrillation, we call it flutter. It looks more like flutter. And so he's got a lot of flutter. More flutter than anything is what he gets what are some of the drug choices? These drugs are not good choices, but that's all we have. And so it's a double-edged sword. Propafenone seems very benign. You could convert flutter from a flutter that is a fast flutter to a slower flutter so that the flutter waves then could penetrate and conduct one-to-one through the AV node. So usually with these drugs, since it might slow the flutter rate, we usually include some other drug to counter that at the AV nodal level, which would be a beta blocker or a calcium channel blocker to block at the AV node in case the propafenone encouraged the atrial flutter to become slower and that might conduct one-to-one. Sotalol used to be a drug used only in the hospital to start with for induction. I've seen people use it more outpatient now with patients with atrial arrhythmias as opposed to ventricular arrhythmias, patients with no ventricular dysfunction, patients without coronary artery disease. Flecainide, called Tembacor, sotalol, of course, is a beta blocker. Flecainide, called Tembacor, basically was a drug that was known in patients with left ventricular disease to cause torsades and VT that was irreversible. It got a bad name. It almost had to be prescribed only by cardiologists for a while, but their medical director was able to get out of that. And so it's available on the market, and it also can cause a one-to-one conduction of by slowing down atrial flutter, so it can conduct one-to-one. And also then there's a recommendation to put the patients on a calcium blocker or a beta blocker on flecainide. And I've seen sudden death in people with normal ventricles with a history of atrial fibrillation on flecainide. And so it can be an evil drug. Amiodarone is known for its toxicity. It certainly is probably the most effective drug against atrial fibrillation, but unfortunately it's a huge downside, and pulmonary fibrosis, eye changes from inclusions, as well as hypo and hyperthyroidism in anywhere from 20 to 40% of people. And so there's some real problems with that. And sometimes the pulmonary fibrosis is just not related to the amount of drug. Sometimes there's a relationship to how much drug is being used. Dronedarone is amiodarone without the iodine moiety, and that basically also meant that it's less effective for some reason. And so it can be, and actually is being used with ranolazine off-label, and is very successful in dogs, dronedarone and ranolazine for atrial fibrillation in dogs with mitral valve disease and mitral regurgitation. And so there's a combination drug that's being tested right now that will be issued in the future. Ticacin is a drug that you used to have to take a test for, and the only drug you had to take a test for. And the pharmacist had to take a test as well. I think that's no longer operant recently, but Ticacin has a bad rep also because of torsades. All these drugs you have to be careful with, and so this is probably up there with amiodarone in terms of be careful, look at kidney function, make sure it hasn't declined, and watch the QT interval. And so that's just a quick rundown on the drugs, and I happen to have been a licensed investigator for all these drugs and had clinics with patients that were exclusively for each one of these drugs. And so here's the echocardiogram, which the left atrium upper limit of normal, always a tall guy, so that's not surprising. And so that's probably athletic, as well as the thickness of the heart. 13 and 13 is athletic, so the athletic heart has to be recognized as an exception in terms of treatment, because it basically, if you did Venn diagrams, it overlaps with pathology, patients with left ventricular hypertrophy from hypertension and so forth. So he is granted exception for these things because of the athletic heart. And so We always check the thyroid, but rarely do we find hyperthyroidism that we didn't recognize clinically. And so some elderly people may have hyperthyroidism that's a T3 hyperthyroidism that's not recognized clinically. And so anybody on amiodarone, which he's not on, has to have thyroid test. And so he's not hyperthyroid, which you would recognize in someone this age. Troponin is negative, CPK, MB is obsolete, HDL 54, he has family history of cholesterolemia, and his cholesterol looks pretty good in terms of the numbers. And this was kind of standard therapy in the emergency room when he came in 2008. Cardizem to slow down the rate, Lovenox, and Cardioversion, usually a TEE cardioversion to make sure there's no clot in the left atrium if you were unsure as to how long he'd been in atrial fibrillation flutter. And so a second cardiologist was seeing him also. I just saw him in the emergency room. So he, because of a family history and because he existed, basically is going to have a stress test, which doesn't make a lot of sense to do a SPECT scan on this gentleman as a workup for paroxysmal atrial fibrillation in someone who's never had chest pain. And so a lot of radiation, especially if you're using thallium and technetium. These combined is 22 millisieverts. A lot of radiation for a 47-year-old guy who's obviously his future is going to be more radiation and more testing. Why people do a workup for coronary artery disease in someone with atrial fibrillation that comes in, it seems to be very common. The yield seems to be very low. And so 14 minutes and 44 seconds on the treadmill basically probably guarantees that a person does not have significant coronary artery disease. And so J-point depression, no chest pain. What can you say about this test? Not much, probably not a good idea. Hypertension, probably not. Probably just blood pressure is up because he came to the emergency room. He's pretty nervous around there. So planar images were normal, okay. Tomographic revealed diaphragmatic attenuation, all right. Normal study. So you know what I think about SPECT scanning with the 40% false positive, 65% false negative, so we'll pass on that. And calcium score, well now that's interesting. Let's go for the calcium score and let's go for coronary CT. So this is looks like 2 years later, 49-year-old, and the burden is certainly on you to thoroughly work up a plaintiff's attorney and not leave a stone unturned. So his calcium score was 17, 2 tiny flecks, non-obstructive in the circumflex coronary artery. So they're non-obstructive, focal, nodular, calcified coronary plaques without any coronary artery disease, just those 2 little plaques. So what would you think that would look like 8 years from now if we repeated the scan because of his interest in wanting to know what his coronaries look like? What do you think will happen to his calcium score? So you can ponder on that for a while and we'll move on. And which arteries do you think will have calcium, and how much calcium do you expect in the next 8 years? So we'll have the answer to that in just a little while. Let's move on and look some more and see what we found out. So no significant coronary artery disease contributing to this patient's paroxysmal atrial fibrillation. And some shortness of breath in the evening. He tried ice water immersion with his face, which has been successful. I did that with my son when he had WPW, and it didn't work, but did not help. And then he took Rhythmol 225, baby aspirin, repeated the medication, came to the ER, was in, I think, atrial flutter again. Atrial fib has been rare for him. Atrial flutter has been more common. If you have atrial flutter, you have somewhere around a 25% chance of getting an atrial fib in the next 5 years, so they're cousins. Continue medical therapy and outpatient follow-up, cardioversion. So now we're getting into cardioverting him when we see him and seeing if he stays out of it. And this was 2010, and the other was 2008, so we had a couple good years from him. He's very reluctant to take medications because of what he knows from malpractice law that he's learned. As you can see, he still has the profound bradycardia of an athletic heart. Left atrium has got some prominent P waves, and that's about it. It looks like the P itself is a little prolonged, so there's an interatrial conduction abnormality that seems to be going on in him. And then here's in June 2010, here's his atrial fib flutter, and not very organized, sawtooth waves in V1, and they sort of lost some organization over here and very little over here, so I guess we call this one fib. The others have been flutter. Don't see any other abnormalities, no evidence of a delta wave. Plan, propafenone, that's pretty benign. Cardizem to block at the AV node if he gets flutter and conducts 1-to-1. Cardioversion is still the option if he's still in it. Radiofrequency ablation if he desires that. So called, went back to sinus rhythm, we canceled the cardioversion. So it looks like either he was going to go back on his own or the drugs helped. And so here's another example. This is a more of an atrial flutter for sure. Sawtooth waves. Some people can localize where the flutter is, whether it's left atrium or right atrium, and then whereabouts in the left atrium or right atrium from the flutter wave morphology, or sometimes you just can't tell the difference. And so this was on no drugs, really, on no drugs at this time. And you can see, again, a parasympathetic individual who is having a slow ventricular response because he's blocking at the AV node. And so this is what we found on his echo again. No surprises, nothing different. Normal because he's a very tall guy. I think he's like 6'4", so normal left atrial size. Mildly dilated aorta, probably normal for his height, and athletic heart as we have decided before. And then TEE with a cardioversion at some point where he was more resistant, revealed that his EF was down, and that's probably left ventricular dysfunction, either secondary to atrial fib or not able to measure it well. We didn't take enough RR intervals to measure it, or it's secondary to a rapid ventricular response, and it's the high heart rate cardiomyopathy that's that reverts on its own. And so he got cardioverted, must have been an atrial fib this time, because it looks like we used 150 joules, whereas atrial flutter used about 50 joules, sometimes even 30. And so amiodarone drip must have been desperate to try to get him out of it. And so he was part of the DECAAF study. And I don't know if you're familiar with the DECAAF study. It was published in JAMA, and you're going to see more about it in this particular case. He was one of our cases, and we wanted to do left atrial late gadolinium enhancement in order to look for fibrosis and to correlate the amount of left atrial late gadolinium enhancement, or fibrosis, if you will, to correlate that with the ability to keep people out of atrial fibrillation, the ability to ablate, the ability to successfully use drugs. And so we rated the amount of fibrosis, and since the study was being led by Dr. Marouche in Utah, we rated them as Utah 1, 2, 3, and 4, where 1 was a little bit of fibrosis, 2 was a little more, 3, we had a 3A, which was sort of scattered fibrosis, and a 3B, which is kind of fibrosis that was kind of glomped together. And then we had a 4, which was a lot of fibrosis everywhere. And all that was quantified. And so we were interested in trying to find out more about this. And so there were 18 centers in the world, and our center was one of the 18. And I had to hunt around to find the right camera. It was sponsored by Siemens, so I had to find a Siemens CT scanner. So I did find one at St. Joe, and we had one of my techs that I worked with at Northside doing MRI, happened to be working at St. Joe now, so we had the combination of having the right CT scanner and then having a tech that knew how to use it. And so we did that and got that organized as part of the DECAAF study, and I sent a lot of patients, and Dr. Herwig became part of it, and he sent a lot of patients too, and we got a good database in atrial fibrillation. I learned how to use the software. The software was centered in Salt Lake City, and you could take a class on learning how to use that, but we sent all the images to the core laboratory, and they were processed, and they didn't tell you the results. It was, double-blind study, so I never knew what this study showed in this gentleman, and still to this day I don't know what it showed, but we did collate all of our data and become part of that study, and it was actually written up and published in JAMA a couple of years ago, and there was a good correlation. Utah 1 could be cardioverted easily, Utah 2 cardioversion easily, Utah 3A where it was scattered fibrosis, most easily cardioverted. B was not so easily cardioverted. B was not so easily ablated. And Utah 4 probably shouldn't even consider ablation. But we did find some interesting things in that some people with paroxysmal atrial fibrillation, which you'd think would be a Utah 1 or 2, had a Utah 4 where they had a lot of fibrosis, and some patients with chronic persistent atrial fibrillation, which you thought for sure would have a lot of fibrosis and be a Utah 4, or only a Utah 1 or 2 with very little fibrosis and could easily be ablated. So that was interesting, the paradoxical relationship that we saw in some patients. So we're back here on recurrent paroxysmal atrial fib. He's back again. It's mostly flutter. He stopped caffeine, he stopped alcohol, avoid Chinese food because of monosodium glutamate, avoid dehydration, make sure his blood pressure is okay, couldn't tolerate the Lipitor because of muscle aches and pains. These are his other medications, and the CT scan that we discussed. And so here's an echocardiogram. He was getting yearly echoes. We still got about 1.3 on his left ventricular wall thickness. The left atrium remained pretty much the same. RV systolic pressure was normal, and so still consistent with athletic heart. And so this is some recordings of, we used Zio heart monitor, and we're looking at the frequency of supraventricular ectopic beats. It looks like 7.1%. Ventricular ectopy was rare, and so he would have stuff like this and some stuff like that, but and then some episodes that would be faster. And so we just want to see what the baseline was. And we got some CT images, so let me show those to you. Why did we do a CT on him? Well, he actually wanted it. He wanted to make sure that because of his father and mother having severe coronary disease, he wanted to make sure that he didn't have that. And so here we are. You can look at his arteries, and we can actually take this off and take a good look at him. And you can see these little calcific nodules. This is a new one, because in 2008 he didn't have any in his LAD. So you figure there was a nidus of calcium somewhere in the LAD that was contributing to these. And in those studies of what was called nanobacteria once upon a time, which actually turned out to be calcium crystals, it was found that frequently on electron microscopy, there are little areas of nanocalcification found in the coronaries, and those are the ones that act as a nidus for coronary calcification later. And so he had no observable LAD calcification in 2008, but now he's got a nice big plaque there, and that's not uncommon, and that means that there was probably some little nidi of coronary calcification in that spot 8 years ago that you would have to find with some microscopic technique. And so enlarging the LAD and looking at it, we're going to see that this guy basically has these plaques that are one and done. And you can tell, I mean, they're round. These are round anyway. They're round and focal. They're usually at branching or near branching. Here's one that's more linear. They're completed. They're positive remodeling. It looks like it's outside the vessel, but it's really inside the wall, and the wall's been pushed out, and that's called positive remodeling. So there's positive remodeling And you can see that there's no unfinished plaques, because sometimes you'll see these where they'll taper out, and you'll see sort of a varying density as it tapers out. And that would be one that has some fibrosis too, and it hasn't completed the calcification or the journey of going from fibrosis to calcification. And all you have to do is have a little tiny plaque there, and years later you will have more and more calcification in that area, because that acts as a nidus for calcium deposition of calcium hydroxyapatite, probably from the inside out. Probably from the inside out is the way that works. And it may be that patients who develop coronary artery disease who are actually not doing ossification things, who are actually doing transcompositional things, there's a little piece of calcium there, that are going from fatty plaque to fatty fibrous plaque, or fibrous fatty to fibrous plaque to calcium plaque. Those seem to be calcifying from the outside, from the inside out, or from the outside in, excuse me, from the outside in. And so they're a little bit different. And so these are just some nidi of calcification that have further calcified. And we saw calcification of the circumflex last time. Let's see what happened to these guys. And we'll take a look at that. Hang on here. See if I can move this up. There we go. And there's a little calcium. That's a couple of little calcifications that were seen before. Some are sort of linear but thick, and others are focal. Let's see if there's any calcium in the right. Of course, all this means nothing. This is inactive disease, and this process of calcification is not transcompositional. It actually is more ossification and deposition of crystals of calcium hydroxyapatite. So we really don't have to keep repeating this, even for his sake, because it doesn't really amount to anything, and it's not a warning. There are no premonitions that I have from looking at this. So let's go back to our presentation. So we've seen that, and the total score is 250, and it went from 17 to 250 in 8 years, which absolutely means nothing. And so you can see following calcium score is of no value in this particular type of patient. There may be other patients it may be useful in, and I'm trying to identify those. I'm trying to identify different kinds of coronary calcification, but in this particular patient it's not useful at all. It just means that he's got more hydroxyapatite crystals that are being deposited on prior hydroxyapatite crystals. So outpatient visit, came to the office complaining of irregular heartbeat. We're getting used to this. I'll come to the office, and he'll be sitting in my office in the morning at about 9:30, and we'll be talking then. And so EKG, atrial flutter, sent back to Moore Hospital. This has got to be sort of a routine where the nurses at the hospital recognize him and call him by his first name, because they've seen him quite a bit. And so you don't want to be recognizable by the nurses in the cardiovascular laboratory. It's not a good thing. Shows you're a frequent flyer, which is not a good thing. And so it looks like we can cardiovert him pretty well, pretty easily, without him becoming resistant with conventional ways. He's been on enough drugs, and so I think it's about time he considered the ablation. And so we did do another MRI study that now the DECAAF study led to the approval of cardiac MRI by the FDA for evaluating pre-ablation Utah classification of the amount of coronary calcification, amount of coronary fibrosis, the amount of left atrial fibrosis. Well, you can imagine what that's like in terms of sectioning the left atrium and super segmenting it into something that you can deal with as a sort of container with walls, and the walls are so thin, and then actually dealing with that in terms of measuring the amount of iodine with late gadolinium enhancement. That's pretty interesting technology. It took a lot of people and a lot of work to develop that. So let's show you the MRI. So this is a cardiac imaging conference, so we should certainly spend some time looking at this. This is the left atrium, and it does look to be enlarged. We can make some measurements here. Let's just drop a perpendicular down from here, and we'll see what we got. And there's a 44.8, so that's enlarged in that dimension. And so enlarged left atrium, part of the athletic heart. We'll measure some fibrosis with late gadolinium enhancement. You can see how difficult it will be to section that out and then define that as a paper-thin structure and measure how much fibrosis is in it is a very big technical challenge that actually was met quite well by a very smart technical team. And so we're looking at the aorta, which looks fine, might be a little big, and we can measure how big that is. We can just do a dimension across here, and we get 40. So not for this patient, it's not very big because it's a tall guy, 6'4", and so it's not so bad. Here's his left anterior descending. It's not. There's the right coronary, and this is not navigator. Oh yeah, it is. This did have a navigator, so there should not be motion artifact from breathing, so it should be easier to see the coronaries in this patient because there won't be as much blurriness. And so that's cool. They're the great vessels, and we go down this way, and that's what we see on this particular part of the study. And here we're getting some nice images that we're going to use soon for late gadolinium enhancement. And this looks like an LGE, late gadolinium enhancement study of the left ventricle, looking at the left ventricle, and it's been nulled, and we don't see any problems with that. Here's another nulled left ventricle without any evidence of any abnormality. Now we can see the left atrium, and the kind of detail that you need to see for late gadolinium enhancement will have to be done when it's sectioned and displayed, so we can't tell much about that with this particular picture or this one. And there's information about acceptable images. That's part of the program, more part of the program for something called MarySite. Let's look at the left ventricle and see if we can watch it beat here. There we go. Now we've got blood going the wrong direction, so let's make it go the right direction. There, that's better. And nice left ventricular contractility. Left atrium doesn't look very big there. See what else we have to show you. And there's the aortic valve. There's the mitral valve. Looks like things are working pretty good. And this is just studies for left ventricular mechanics. And I think that's it. So now we can show you the post-processing results of having used the program for defining left atrial late gadolinium enhancement. Here's the Utah classification to give you a guideline. So this is Utah 1, and looks pretty good. A little fibrosis up there by, looks like pulmonary vein, superior right pulmonary vein. Looks like we're looking for the left atrium from the backside, so that would be superior left pulmonary vein. And then another area of fibrosis, pulmonary veins, upper, lower, usually they're 4. So there's a lot of anatomical variability. The backside is usually where they start to look and sort of see what's happening here, and you can see this sort of dispersion. So this would be 3A, and if it was glompy, it would be 3B. And then you can see stage 4 is a lot of confluent areas of fibrosis. So the left atrium baseline, or the muscle, was blue, and the fibrosis is sort of greenish here, greenish and whitish, and the pulmonary veins are grayish. And so this shows you the patient. So let's look at him and see how he compares. And there's the posterior. We can stop that and say, well, looks like a lot of fibrosis. It doesn't look like a 2. it looks more like a 3. So it's a 3. It's not quite a 4. Maybe getting towards a 4. So maybe it's a 3B because they are confluent. So it looks to me like a 3B. These are the pulmonary veins. Now we can come around the other side. See what it looks like. Now on this side, it doesn't look as bad on this side. One side looks like it's got more than the other side does. So I'm going for a 3B. And so here's the MRI that you saw rotating. This is the same patient. And this is some numbers that they're calculating in terms of pulmonary veins. They got 2 and 2. So, and they look and see there's no pulmonary vein stenosis. Of course, he hasn't had any previous ablation, so we don't suspect he'd have that anyway. And then here's some left atrial regional analysis looking at the late gadolinium enhancement of different areas. The left pulmonary veins, 4.3. The total was 17.6. And posterior, anterior, you can see the different sections. Left pulmonary vein being the most, posterior being the most, 29%. Posterior of the enhancement is posterior. And there's some more numbers expressed in different ways. There's the volume, surface area of the region, and this is what we got in terms of total left atrium. 172 centimeters squared is the area if you were to spread it out. So they basically, I think this is useful for atrial fibrillation. I don't know the use for it with atrial flutter. And so the decision was made to ablate, and he had radiofrequency ablation. The left atrium, I don't know if it was a left atrial flutter or if it's a right atrial flutter. You know, certainly had some atrial fibrillation in the past. There's a relationship. Sometimes people would go for the atrial flutter and go to the right side. Sometimes the right atrium. Sometimes people go to the left atrium, take out the flutter and fib both at one time, and then he's going to be followed up. And so we have here onset of paroxysmal atrial fib, status post left atrial radiofrequency ablation, and he has his symptoms. He's highly symptomatic when he gets atrial flutter fib. And so here's his EKG, and it's a flutter, which 95% of the time he's been flutter. And so here's his flutter waves, and you can see the rate. It's usually the same, variable ventricular response, with some varying in the R intervals. So the plan was to try some flecainide, see if that cardioversion didn't work. Cardiovert electrically, that worked. It always works. Patient atrial flutter again a few weeks later, discussed with Dr. Marouche. He's going to bring him back and do ablation on the right side. He stayed in flutter so that he could go back and be in flutter at the time of the attempt for the next ablation. And these are the kind of things we look at in terms of some left atrial anatomy and some possible origins from the pulmonary veins where you get an ectopic beat that organizes and is the cause or the start of the atrial fibrillation flutter, and then it starts propagating around. You can also get rotors where you have actually little like tornadoes or whirlwinds of electrical activity that are going around certain fibrotic areas. And so the idea is to take out the origin, which is pulmonary vein ablation, and then sometimes lines. Whether the lines are effective or not, I can't tell you, but sometimes lines in the left atrium to take out other potential areas that might be connecting in a macro reentry circuit. And then if you have rotors, taking out rotors is another way of attempting a significant ablation. And so this is a counterclockwise pathway. Both of those are. And so you do 2 pulmonary veins at one time, you go around them, and then you put a line across here. Here you go around them. You can do cryo and put a cryo balloon in, ablate. Cryo balloon, you got to be careful with all this stuff that you don't wind up ablating a little bit of the esophagus and perforating left atrial esophagus and getting a connection there. And then here's some little ablations where you're doing pointillism type ablations, taking out little segments. And then we were talking about for a minute the DECAAF study, which you're familiar with, which I've had a lot of experience because I was part of. There's a Cabana study that we started also where we take patients that we define as having some atrial fibrillation that's paroxysmal plus having this as a new onset plus having diabetes or another risk factor like left ventricular hypertrophy or hypertension. And those patients, the question was, should you go on a drug, which has a 40% success rate in 1 year, or should you be ablated, which has a 70% success rate in 1 year, and see which one's the best. And so it's a double-blind randomized study where a patient would be seen in clinic by me, and we would make that decision and by randomizing, and then the patient would go off to Dr. Herwig and have something done and then return, and we would take care of the patient. And then we got a lot of patients in the DECAAF study. It took a long time to get enough patients to be able to say anything. The study's closed now. It took a big effort to get the study going and to get enough patients because everyone was ablating patients to start with, and or they were putting on drugs to start with because of whatever their prior convictions were. And so the Cabana should tell us a little bit about what's the best thing to do with these risky patients that you see for the first time in atrial fibrillation. The AFFIRM study where basically patients were put on rate control and anticoagulation and compared with that of getting them out of atrial fib, and it was found satisfactory that a group of patients who are asymptomatic with atrial fibrillation could be treated with anticoagulation and with rate control. And then CHADS has been tested against CHADS-VASc and CHADS-VASc in terms of deciding who's at highest risk for developing a thrombus or having a stroke. And it turns out that it looks like the best selector is the CHADS-VASc, which is the European selector. It looks like the American CHADS wasn't selective enough. You needed these other risk factors factored in. And so this is for congestive heart failure, hypertension, age, and the first age cutoff is 65. And then we're interested if they had a previous stroke, if they have diabetes, and we're interested in if they're female, if they have vascular disease, and then the next age marker is 75. And so we add that up, and if it's 2 or greater, you need to be on anticoagulation. So that was our schema that we use, and everyone has pretty much converted the CHADS-VASc as being superior to CHADS in terms of being effective anticoagulation in the right patient to keep them from developing a clot, which those clots can be devastating because they're big clots in the left atrial appendage. They're firmly adherent, and when they dislodge, they close off like a middle cerebral artery, and that can be devastating if you don't go in with a solitaire and pull it out. So big adherent clots leading to devastation. So that's the story about this particular patient. Thank you for coming today. This is our 50th recorded broadcast, and so we had a good case to talk about, and we'll see you next week. Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye.